Clinical Practice Guidelines review, and this was released in 2020. My name, of course, is Mohammed Hashmi. I'm one of the first-year pulmonary critical care fellows, and I'll try my best to kind of walk you guys through this guideline review. Just trying to change the slide. Okay, perfect. So starting off with the diagnostic criteria, just so we're on the same page in terms of how do we, number one, diagnose non-tuberculous mycobacteria. There are several subspecies. And basically what you want to focus on is this is the same guideline from 2007, which is carried forward to the 2020 guidelines. You have to have a constellation of a couple of factors. Number one, you have to have clinical evidence of disease. So you have to have pulmonary or systemic symptoms. You have to have radiological evidence, so nodular or cavitary opacities on either chest radiograph or CT. And then something that's very important that I'll go into a little bit more detail is actually the microbiological evidence. So you have to have at least 2 separate expectorated sputum samples that are positive. You have to have positive culture results from at least 1 bronchoalveolar lavage or wash. And you can even have transbronchial lung biopsies that show mycobacterial histological features or granulomatous inflammation that's usually associated with mycobacterial infections. Just to harp on real quick on the radiological things. So one of the big distinguishing features in mycobacterial disease is actually the presence of nodular bronchiectatic disease versus cavitary disease. And that actually has a big effect on the treatment regimens that we utilize. So this is an example of a patient who had nodular bronchiectatic disease. You see on the right side of the screen, a patient, this is a classic tree and bud kind of pattern that's seen in the lower lobes, most commonly, most evident here on the right lower lobe. And then on the right, the left side of your screen, you see a patient with the same patient in the upper lobes, you have very extensive bronchiectasis. We continue the images going down for this patient, you would also see bronchiectatic changes in the right middle lobe and inferior lingular segment as well. This is opposed to what you would see in a patient with cystic or cavitary, fibrocavitary disease. This is a CT from a patient who has pulmonary Mycobacterium avium infection, and they have a pretty significant cavitary disease. And it's important to distinguish these two radiologically because the treatment is different. Regarding the sputum cultures, why is it that we want multiple sputum cultures? This is something that is pretty evident to us, but just in case someone wants to know, and this is something that I like to learn as well, was that non-tuberculous mycobacteria can actually be isolated from respiratory specimens just due to environmental contamination. So some patients who may have it isolated from the respiratory tract don't necessarily show evidence of progressive disease. And that's why you want to have at least more than two or more sputum samples that demonstrate the growth of non-tuberculous mycobacteria. And of course, they have to be the same subspecies. So if it's Mycobacterium avium, you want to have that grow again. If it's Mycobacterium abscesses, that has to grow again as well to establish diagnosis of the disease. Given the slow course of NTM pulmonary disease, we usually have a prolonged interval between the expectorated sputum cultures to establish that this is not just transient contamination of the tracheobronchial tree, but this is actual disease that the patient is infected with. So we usually have 3 respiratory samples taken over an interval of at least a week to establish that diagnosis. One interesting question that usually comes up is it better if we just get a bronchoalveolar lavage, or is it sufficient enough to have expectorated sputum samples and culture those? So if you look at several small studies in the past, they actually reported that yes, bronchoalveolar lavage fluid was more sensitive than spontaneously expectorated sputum cultures to diagnose nodular bronchiectatic non-tuberculous mycobacterial disease. However, this is one of the largest studies that I've put up on the screen in which they actually evaluated that specific question. This was a total of 132 patients diagnosed as affected by Mycobacterium avium complex disease during that period. And if they were smear negative, they underwent a bronchoscopic examination and underwent a bronchial wash smear and culture, and then they underwent expectorated sputum culture as well. And you can actually see in these patients that if you look at the bronchial wash smear positivity rate, it was 43%. And if you compare the bronchial wash culture and sputum culture positivity rate, it's just 84% to 81%. So long story short is, yes, your expectorated sputum cultures are actually equivalent in sensitivity to your bronchial wash cultures. The advantage here, I will say though, is that bronchoscopy, number one, obviously is very helpful if you have someone who doesn't produce sputum, but also you can get a smear relatively pretty rapidly and establish the diagnosis without having to wait on the culture results to come in. So that's kind of just for your information to know where we stand in terms of BAL versus expectorated sputum sample. So let's start off with the clinical scenario. It's nothing fancy, but just to kind of set the stage for how we're going to talk through each of these subspecies and their treatment. So you have a patient comes in, they have an active non-tuberculous mycobacterial infection. We don't know which subspecies it is yet. And she only has a mild cough, shortness of breath. So the question is, how are we going to proceed? The big questions just to start off with is, number one is, yes, this patient tested positive, but do I have to immediately jump on and add antibiotic regimen, or can I wait and watch for progression of the disease? And what does that look like for a patient? Or if I do decide to treat them, do I begin empiric therapy based on recommended regimens, or do I await susceptibility? So let's answer those questions one by one. So the first question is watchful waiting or not. So no randomized controlled trials have been conducted to examine the impact of treatment on survival, specifically in patients who were left untreated or treated. And there is some limited retrospective observational data that's failed to demonstrate survival benefit in patients who were treated versus watchful waiting. However, what is important to understand is that not all, and basically actually that is supported by the fact that not all patients who have non-tuberculous mycobacteria isolated from a respiratory specimen, even if they meet the ATS-IDSA guidelines for diagnosis, will develop progressive pulmonary disease. That's something that I wanted to highlight here in this study, which is basically looked at exactly that question. How does the natural history of this pulmonary infection progress in patients that are left untreated? This was 488 patients with MAC pulmonary disease in Taiwan, and they were followed for at least 1 year. And in that 1 year, about 60%, 62.5% specifically demonstrated progression of their disease. Who were the patients who were at risk to developing progression of disease? They were patients who had a acid-fast bacilli smear positivity at the time of diagnosis, or had fibrocavitary disease or extensive bilateral radiographic disease. So those are your patients you want to watch out for. They're at high risk of progression to overt pulmonary disease. Among the patients who did meet the diagnostic criteria, if they were followed up for 5.6 years, actually 51.6% of those underwent spontaneous sputum conversion even without any treatment. So one thing is that, a subset of these patients don't even develop progressive disease. And then those who do develop progressive disease, there is actually a subset of them can undergo spontaneous sputum conversion, up to even half of them in at least a median follow-up in this study was about 5.6 years. And what are the predictors of that? So if you had to kind of filter through your patient list and look at who do I think would spontaneously convert, some of the predictors they looked at in the same study were patients who had a younger age, which makes sense. One thing that was very surprising actually to me was a higher body mass index. And one thing that makes sense is having a negative sputum acid-fast bacilli smear at initial diagnosis. Those were all predictors of patients who would spontaneously clear their sputum even without treatment. So one thing that we often look at in our studies is, okay, their sputum is converting to negative, and that's all we care about. But sometimes to the patient, that doesn't matter as much as things like quality of life. So there's actually a study that was actually also done evaluating the quality of life of patients as they were treated for Mycobacterium abscesses infection. And the way they did this was they actually had a St. George respiratory questionnaire, which is usually used for COPD. And the higher the score, obviously, the poorer their quality of life, then the lower the score, the better their quality of life. And you can see at baseline, at the time of diagnosis, these patients had a baseline score of 35. But when they're followed up at 3-month intervals, during that time, their St. George questionnaire score actually drops significantly, and it indicates improved quality of life when they're followed up at each of these 3-month intervals. So there's what I would like to say to kind of summarize that point is that there's no specific hard point that you can use to decide whether you want to just watch your patient for progression or you want to treat them right away, but it is a combination of clinical factors. Is your patient young of age? Do they have an organism that's very responsive to antimicrobial therapy? Do they have an organism that is known to cause very severe disease and high mortality? Are they Do they have immune suppression at baseline? Do they have mild symptoms, or do they have severe symptoms that are affecting their quality of life? Those are all things you want to keep in mind when you're kind of deciding and having a discussion with your patient about prospective therapy options for them. The second question was, we have this patient with undifferentiated non-tuberculous mycobacteria, and we decide, okay, we're going to treat them. Should we just treat them based on on an empiric regimen, or should we do that based on their susceptibility test results? So this is actually a very interesting aspect of non-tuberculous mycobacteria, and actually differs by different subspecies. So starting off with Mycobacterium avium complex, which is usually our most common NTM infection. In Mycobacterium avium complex pulmonary disease, retrospective case series showed that in vitro resistance to clarithromycin was actually associated with worse outcomes than susceptibility to clarithromycin. This is a study where they had 39 patients, and of that, 71% actually converted their SPUTA to negative with the antimicrobial therapy. But if you break it down even further, you'll see that 84% of that subset was clarithromycin susceptible. If you looked at the patients who had clarithromycin resistant strains, only 25% of those patients actually ended up clearing their cultures. And this basically shows you a very direct association with macrolide resistance to positive or negative outcomes in these patients. If you look at the other two components of the usually recommended regimen, which is rifampin and ethambutol, it's actually interesting is that the randomized trial found no association between in vitro susceptibility to these two agents with the number of failures of treatment and relapses in these patients. So it doesn't matter if they're rifampin sensitive, intermediate, and resistant, or ethambutol sensitive, intermediate, or resistant. It really doesn't affect your percentage of failure of treatment or relapses. It's just the macrolide in patients with Mycobacterium avium that determines kind of their success rates, so to speak. Regarding Mycobacterium abscesses, amikacin is actually one of the most important components of that drug regimen used for the treatment of that disease. And resistance to it is caused by a mutation in the 16S RNA gene, and it usually ends up causing a high MIC, usually more than 64, that is associated with this mutation or previous exposure to amikacin. Now, in the case of looking at their outcomes, there was actually recent phase 2 and 3 clinical trials evaluating the efficacy of inhaled liposomal amikacin in patients with refractory Mycobacterium abscessus or Mycobacterium avium complex. And in the big gist of the slide here is that if these patients were found to have that 16S RNA mutation, or their MIC was more than 64, none of those patients achieved culture conversion in this treatment regimen. The same way we talked about macrolide resistance that was important in Mycobacterium avium, the same way macrolide resistance is also an important factor in Mycobacterium abscessus. And in this retrospective cohort, you can see that patients that were treated with the standard regimen, if they had the presence of clarithromycin resistance, that was clearly associated with worse outcomes. You can see here that in the patients with resistance on univariate analysis, that's associated with poor microbiological response. In regards to Mycobacterium kansasii, it's pretty straightforward in terms of basically it's known that resistance to rifampicin is associated with treatment failure. And a lot of this data comes from a very small study, admittedly, but it was basically a study of 28 patients. They're randomized to, they're being treated with sulfamethoxazole. And in those patients, those 28 patients, whenever there was treatment failure, all those isolates frequently exhibited resistance to rifampin. And based on that study, basically we conclude that in the treatment of Mycobacterium kansasii, resistance to rifampin is actually one of the more important variables that decides positive outcomes for these patients. So kind of just to summarize all those different data points, if you look at Mycobacterium avium, both susceptibility to macrolides and amikacin is important to establish before over empiric therapy. In the treatment of Mycobacterium kansasii, rifampin susceptibility is important to establish this over starting empiric therapy. And in patients with Mycobacterium abscessus, the same way the resistance to macrolides and amikacin is important to investigate and establish rather than just starting empiric therapy. The next few slides, what I'm going to do is I'm going to try to break down the treatment of each of the different subspecies of non-tuberculous mycobacteria and kind of go through different questions you may ask yourself if you see a patient with these diseases. So starting off with Mycobacterium avium complex, you have a clinical scenario where, very simple, your patient's microbiology eventually comes back and shows you that it's Mycobacterium avium complex. Imaging, thankfully, for this patient doesn't demonstrate any cavitary disease. But what does that mean for you as a physician who's trying to treat this person? Would you start off with a macrolide? We just established in the previous few slides that macrolides are very important in the treatment of MAC infection. So let's say, yes, okay, we want to use a macrolide. Would do we use azithromycin or clarithromycin? Do we use the addition of IV or inhaled amikacin? Why not use 2 drugs instead of 3 drugs? Why give it to them daily or versus just 3 times a week? Is there any problem with giving it daily? And how long should I treat my patient? So there are several questions that come to mind in the treatment of this very complex disease. We'll start off with the first question, which is, in your patient with macrolide susceptible Mycobacterium avium complex, do you use a macrolide regimen or do you not use a macrolide regimen? And in spite of the widespread use of macrolides for treating MAC disease, there have actually only been 2 randomized controlled trials comparing a macrolide containing regimen with a non-macrolide containing regimen. The British Thoracic Society actually did a trial, which I've highlighted here on the screen, with patients with primarily cavitary MAC pulmonary disease. And what they did was they basically randomized them to either receive clarithromycin, which is our macrolide, or ciprofloxacin, which is a fluoroquinolone. The gist of this is that the results showed that, number one, clarithromycin had a lower failure relapse rate than ciprofloxacin group. It was 13% versus 23%. And on top of that, it was also tolerated better. More patients on the clarithromycin group compared to the ciprofloxacin group completed treatment and as allocated and were alive and cured at the end of 5 years. This was significant difference. It was 30% versus 20%. So your macrolides are superior to your fluoroquinolones in this case. This is a systematic review that was recently published and reported basically a sustained sputum culture conversion incidence rate for macrolide containing regimens versus non-macrolide containing regimens. And you can see here that the rate is 0.53 versus 0.32 on the intention to treat analysis in support of using macrolide containing regimens. This is actually something that's very interesting, is that if you actually look at that systematic review and you look at the quality of the data from all the studies that were pooled in it, the sputum conversion in response to macrolides actually, the results, favor the use of macrolides. The more the evidence from these studies was classified as good as opposed to low quality evidence. So basically this graph here, to kind of explain why I put it up, is this is a risk ratio of how likely you are to clear your sputum cultures if you use a macrolide free regimen versus a macrolide containing regimen. So basically, the lower you are on the y-axis, the more you favor a macrolide containing regimen. And you can see as the evidence goes from low to good in these pooled studies, you see that there's a significant trend towards the use of macrolide containing regimens as opposed to those without it. Another point is the strongest available evidence for the importance of a macrolide is actually when you have the loss of it in the regimen. So in the setting of macrolide resistance, sputum cultures, actually the conversion rate falls from 80% all the way down to 5 to 36%. And this just kind of basically delineates how important your macrolide is in the treatment of MAC disease. So the recommendation obviously falls to using a macrolide over a 3-drug regimen that does not contain a macrolide. The second question is, okay, we decided we're going to use a macrolide. The studies that have good evidence all tell us to use one, but which one are we going to use? Are we going to use azithromycin or are we going to use clarithromycin? Is there any difference? And that's kind of what we're going to investigate next. So this is a systematic review that basically compared a large number of studies that used azithromycin or clarithromycin. And you can see that the pooled sputum culture conversion rate at 6 months, end of therapy, and sustained conversion after treatment, there is no difference between azithromycin and clarithromycin. Both their ratios, the pooled conversion rates are the same. then why do we favor one over the other? So this is actually a very interesting study that I wanted to put in here, is that when you look at the pharmacokinetics and interactions of azithromycin and clarithromycin in the setting of using rifampins or rifamycins, that's where the distinguishing features come in. So here you have in this graph, which I've tried to highlight with the red box, is you have your maximum concentrations of clarithromycin with and without rifampicin, and azithromycin max concentrations with or without rifampicin. And you can see that there's a significant drop in the concentration of clarithromycin when you give it with rifampicin. Whereas azithromycin, yes, it falls, but not as much. There's another factor to this, is that clarithromycin, while its concentration falls with the use of rifamycin, it actually increases the concentration of rifabutin, and that can lead to rifabutin-induced uveitis. And because of this factor, it's felt that azithromycin is a better choice over clarithromycin because of better tolerance, less drug-drug interaction. Just to be aware of things that you should also look out for when you're treating your patients with either of these agents is that azithromycin is associated with hearing loss, some GI symptoms, whereas clarithromycin is associated with bitter taste and nausea, but also elevated hepatic enzymes. So those are just some things to keep in mind when you're treating with either one of these macrolides. But again, as I mentioned, because of the drug-to-drug interactions, we recommend azithromycin-based treatments rather than clarithromycin-based treatments. The third question is, so we have a patient who has Mycobacterium avium complex. We decided we're going to use a macrolide. We decided we're going to use azithromycin. Everything's going okay. Then we decide we want to try to see, is there any evidence to suggest that if I add IV amikacin or streptomycin, will that make a difference to my treatment at all? So this is actually one randomized control trial that evaluated the impact of the addition of streptomycin to macrolide-based oral therapy if given for 3 months in the beginning. So there's 146 patients in the study. They had both nodular bronchiectatic and cavitary disease, and they were randomized to receive their regular oral regimen with or without streptomycin. And you can see that the sputum culture conversion rate is actually significantly higher in the patients who receive streptomycin. Right at the bottom of the graph, you can see 71% versus 50.7% is the sputum culture conversion rate, and with significant difference. One thing that's important to also realize, however, is when you continue to follow these patients, though, there's no significant differences in microbiological recurrence rates or clinical improvement based on clinical symptoms or radiological findings. But the good news is, at the same time, there's also no increased adverse events in the patients who receive this additional streptomycin. So the adverse reaction rate in both groups was about the same, and there's no significant difference between those. There is further evidence in retrospective studies that if you add parenteral aminoglycoside for more than 6 months with adjunctive surgery in patients with macrolide-resistant pulmonary disease, there's actually improved outcomes in these patients in terms of culture conversion. And for that reason, basically the recommendation is, if you have a patient with severe cavitary or advanced bronchiectatic disease, or they have macrolide-resistant disease, then you should add IV amikacin, because again, culture conversion rate is better. There's no increased risk of adverse events, and that should be included in the initial treatment regimen. It is felt that you should do this for the first 2 to 3 months of the initiation of the regimen. And in terms of should you use streptomycin versus amikacin, there's no, unfortunately, randomized trials to compare those two, but streptomycin is slowly falling out of availability in several countries, so we usually tend to drift towards amikacin. Speaking of amikacin, now, is there any benefit of doing inhaled amikacin versus no inhaled amikacin? So far, to summarize, we have a patient with MAC. We've given them macrolide therapy. We're doing azithromycin, and if there's severe disease, we'll add parenteral amikacin as well. But then the question comes in: is there any point of doing inhaled amikacin versus no inhaled amikacin? And this is actually interesting. There are reports evaluating the use of inhaled amikacin as part of a multi-drug regimen, but they're mostly targeted to a subset of patients that have treatment refractory disease. So these are patients who haven't cleared their cultures despite 6 months of therapy. And if you look at the results from these retrospective series, there's about 5 of them with a total of 138 patients. The clinical response rates are kind of swing very wildly, anywhere between 18 to 67%. And there are also associated side effects with this treatment, anywhere between 8 to 38%. So kind of very hard to distinguish based on on the retrospective data whether inhaled amikacin is a good idea or not. However, thankfully, right now we have a randomized control phase 3 trial that's actually investigating the use of liposomal inhaled amikacin when added to guideline-based treatment for refractory Mycobacterium avium complex. This was a study where they added the liposomal inhaled amikacin, and they followed them up for 12 months off of treatment and kind of looked at their culture conversion rate. And if you look at the culture conversion rates, you see that in the patients who received inhaled liposomal amikacin, there was actually culture conversion was achieved by 29% of those patients versus 8.9% of the patients who received the guideline-based therapy alone. On top of that, also, if you look at their the growth of mycobacteria on a semi-quantitative scale, you can see that there is actually a significant difference between the two arms. Obviously, there's significantly lower growth in the mycobacterium arm as compared to the arm that uses that received placebo. And then when they entered the open label phase, and so what that means is both arms then start to receive the liposomal inhaled amikacin. The growth actually fell in the control arm and matched that of the arm that was receiving liposomal amikacin from the beginning. So that's very interesting. It shows you the effectiveness of adding that liposomal amikacin. And on top of that, remember we talked about it's not always about the sputum culture conversion. It's also about how does the patient feel, what is their functional status, what is their quality of life. And these patients actually, if you look at their mean change from baseline on the 6-minute walk test, there's a significant difference on day 84 and day 168 in the distance traveled in a 6-minute walk test in these two arms. In patients who fail treatment with an initial MAC regimen, we still find that they have in vitro susceptibility to amikacin. And hence, for that reason, it's suggested that in patients with MAC pulmonary disease, you don't initially add inhaled amikacin or liposomal amikacin as part of the initial treatment regimen. But yes, if they are patients who have failed initial therapy after 6 months of guideline-based therapy, so their sputum cultures are still positive, then adding amikacin, that's liposomal inhaled form, is recommended instead of just continuing the standard oral regimen. In patients, then we come to the fact that, why are we using so many medications? Can we just whittle this down to 2 drugs instead of 3 drugs? And this is actually very interesting. I actually liked this question very much because there's actually, interestingly, only 2 randomized studies that compared a 2-drug regimen to 3-drug regimen. And the one that I actually put up on the stream is the only one that they included a macrolide in, which is obviously recommended. This was a single center open label study from Japan, and they had patients with previously untreated Mycobacterium avium complex disease, and they were randomized to either 3 drugs or 2 drugs. One thing I will obviously point out as a caveat is that the dosing of the clarithromycin in the 3-drug regimen was actually well below what's recommended in the ATS-IDSA guidelines. But looking at their results, it's actually interesting to see that in the intention to treat analysis, you can see that their culture conversion rate was actually lower in the 3-drug regimen compared to the 2-drug regimen. But again, my caveat to this is that the dosing for clarithromycin was well below what's recommended. It's a small sample size. There was a lot of dropout, and this was an unblinded study, so we can't really go by the results in this study. But then the question then comes up, why do we then choose a multi-drug regimen in the first place, right? So the priority in the treatment for Mycobacterium avium is actually preventing the development of macrolide resistance. The best drug that's thought to be a companion to macrolides is ethambutol. But on top of that, we add rifampicin, and the reason why is that this was a randomized control trial where they added rifabutin to clarithromycin and ethambutol, and there were obviously 2 arms. One arm got the rifabutin, one got a placebo, and even though there was no improved bacteriological response to adding rifabutin, it was the same. There was actually significantly lower development of macrolide resistance in the arm that used 3 drugs versus 2 drugs. So until additional evidence is provided that suggests that the acquisition of macrolide resistance is the same in 2-drug regimen versus 3 drugs, the panel that decided these guidelines recommended 3 drugs at least, which includes usually macrolide, ethambutol, and rifampin. So now we've decided on, okay, we're going to do a macrolide regimen. We're going to do 3 drugs. Then the patient asks you, do you have to take this every day, or can I just take it 3 times a week? There have been 3 prospective non-comparative studies of azithromycin-containing regimens for MAC pulmonary disease. One of them, which was the most interesting, I put up on the slide here. And this was basically what they looked at here was they looked at bacteriological response in terms of culture conversion to negative in 3 arms. The first arm, which is your A column, actually had patients with daily azithromycin and daily companion medications. B was a combination, so it was intermittent azithromycin with daily companion medications, and C was your everything was intermittent, so it was 3 times a week. So just to summarize, A column is your daily medications, C column is your 3 times a week medications. And you can see that the bacteriological response is practically the same. You have 59% conversion in patients who got daily medications, and you have 65% conversion in patients who got intermittent medications. This is another large retrospective case series that included 180 patients. And basically the summary of this is that 85% of patients with the intermittent regimen compared with 88% of patients with the daily regimen had negative sputum conversion. This is a non-significant difference. But the big reason why we harp on using intermittent medications here is that there was a significantly greater number of patients treated with daily medications who experienced medication intolerance and had to switch into an intermittent regimen. And that's something I highlight in the next slide here as well. This is another study that was done to compare daily versus intermittent therapy. And you can see here that 46% of the arm that had daily therapy had to change their antibiotic treatment regimen versus only 21% in the intermittent therapy group, which was a significant difference. The one caveat to this is, however, that treatment outcomes when you look at cavitary pulmonary disease is not as good for intermittent therapy. There was one prospective open label multicenter trial that actually reported only a 4% sputum culture conversion rate in patients who had cavitary lung disease compared with non-cavitary lung disease. And they were 4 times more likely to demonstrate the patients who had non-cavitary lung disease versus cavitary, they were 4 times more likely to clear their sputum, and they were 4 times or almost 5 times more likely to have improvement in their CT radiological findings as well. So that's the reason why in the beginning, when I gave you the clinical scenario and we talked about this patient not having cavitary disease, this is actually the reason why it's important to make that distinction between fibrocavitary disease and just nodular bronchiectatic diseases, because intermittent therapy is actually not effective and has very poor outcomes in patients who have cavitary disease. So long story short is, if you have a patient with just nodular bronchiectatic disease, 3 times a week is usually recommended over daily therapy. But if you have cavitary disease, you want to use your daily macrolide-based regimen rather than 3 times weekly. The second thing is, the last question is basically, how long do you want to treat this patient, right? So would you want to give them less than 12 months of treatment or more than 12 months of treatment after culture negativity? This is a single center retrospective study that basically didn't randomize, but basically there were patients who were unable to get 12 months of therapy because of medication intolerance. And so they were only treated for less than 12 months. And then there were 180 patients who were treated for more than 12 months. And in the arm that received less than 12 months of therapy, only 22% of those patients cleared their cultures versus 86% of patients who completed at least 12 months of therapy. And very simply, that's the reason why we recommend that you give these patients treatment for at least 12 months after culture conversion. To summarize for MAC, and I promise this is probably one of the longest subspecies, all the others are much shorter, but just to summarize the treatment for Mycobacterium avium complex, you want to treat them with a 3-drug regimen. It has to have a macrolide in it. We suggest using azithromycin over clarithromycin. You want to make sure that in your patients with cavitary or advanced severe bronchiectatic or macrolide resistant disease, you add parenteral amikacin or inhaled amikacin. And in patients who have cavitary disease, you want to give daily treatment versus thrice weekly. And you want to treat all of these patients for at least 12 months after culture conversion. Again, if they haven't cleared their cultures after 6 months, then you escalate to using the inhaled liposomal amikacin. In the treatment of Mycobacterium kansasii pulmonary disease, this is much shorter, and it kind of parallels the treatment for MAC. The first question is, number one, should you use an isoniazid containing regimen or a macrolide containing regimen? To be very short, no randomized clinical trials have directly compared isoniazid versus clarithromycin. But in treatment outcomes, when they looked at regimens containing isoniazid treated for at 9 to 18 months, they're excellent cure rates. They're 80 to 100%. So they're much better than your cure rates that you see with pulmonary MAC. Very low relapse rates, 2.5 to 6.6%. When they looked at the retrospective cohort studies evaluating the treatment regimens containing clarithromycin instead of isoniazid, you had the same thing. You had similar cure rates, 80 to 100%, very good outcomes in these patients, especially in the patients who completed the entire treatment regimen. Cure was at 100%. For this reason, you can use a regimen that contains either isoniazid or macrolide for Mycobacterium kansasii because of the excellent outcomes. In these patients, do you want to add IV amikacin just like we were talking about for MAC? Well, that is a question that is basically answered by the fact that we just went over these studies that have oral regimens without any inclusion of additional aminoglycosides, and they have such high culture conversion rates, 80 to 100%. What more could you ask for? There's actually studies that have investigated the addition of streptomycin that's added to an isoniazid containing regimen. And the culture conversion rate for those studies showed a very good response. So they cleared their cultures in 95% of those patients. So very similar to our regimens that don't contain streptomycin. But the big thing that I want to point out here is in those studies, there was actually 14.7% of those patients actually had adverse events leading to discontinuation of that IV agent in about 10% of those patients. So long story short is if you have a regimen that works very well, 80 to 100% patients are being cured, why would you add an additional agent that in 10% of these patients, they can't even tolerate and usually have some kind of adverse event? So for this reason, it's not recommended to add IV amikacin or streptomycin in the treatment of Mycobacterium kansasii. In patients who have Mycobacterium kansasii, do you want to use a fluoroquinolone or not? This is pretty straightforward. Basically, yes, in vitro testing of kansasii isolates show a good response to fluoroquinolones. So if you have, because we have better evidence for isoniazid and macrolides, we use those as first-line therapy. But yes, if you have a patient who becomes, who has rifampicin-resistant disease, you want to replace that rifampicin with the fluoroquinolone. And just to harp back to my previous slide, remember we talked about in Mycobacterium kansasii, the main determining feature or factor in the treatment outcomes is the rifampin resistance. So in those patients, you have poor outcomes and you want to substitute the rifampicin with the fluoroquinolone as a second-line regimen. The similar question to what we asked in MAC is, you want to do 3 times per week or want to do daily treatment? So unfortunately for isoniazid, there's no studies that have compared daily versus intermittent therapy, but clarithromycin, yes, there have been studies that have compared 3 times a week treatment with daily treatment, and they have equivalent success rates. Very small studies, obviously, in these patients with non-tuberculous mycobacteria, but in this patient with 14 patients, they converted, all 14 converted sputum cultures and remained relapse-free after 46 months. And even a subset of those patients even had cavitary disease. Actually, a majority of those patients, 9 of 14 patients had cavitary disease. And still in those patients, when you use this intermittent therapy, it was highly, highly effective. So cavitary pulmonary disease, we think obviously, especially in the case of MAC, has higher morbidity and mortality, and we think we want to use a more aggressive approach. But it's unclear, honestly speaking, to what extent this applies to Mycobacterium kansasii, given the fact that we have such good outcomes even in cavitary disease. Regardless, the panel decided that, if you have just nodular bronchiectatic disease, you can use 3 times a week regimen over daily regimen. If you have cavitary disease, they usually want to sway you towards using daily treatment versus 3 times a weekly treatment. And in patients who have rifampin, in patients who are treated with, who have rifampin-resistant disease, you want to add a fluoroquinolone as second-line therapy. How long do you treat these patients? There's actually, just going back to the same studies we went over, if you look at their pooled recurrence rate from 12-month regimens in these is about 5.4%. So pretty good, pretty low. There was only one study that actually tried to investigate a smaller 9-month regimen, and this was the British Thoracic Society evaluated a 9-month regimen for these patients. And in those patients, they had a great bacteriological response. They had 99% culture conversion, but 10% experienced disease recurrence. And just because that's higher than our 12-month regimen, we recommend to use this to treat these patients for at least 12 months because we have strong evidence to suggest it has lower rates of recurrence. So just to kind of summarize our treatment of Mycobacterium kansasii, you want to use rifampin, ethambutol, and either isoniazid and a macrolide. You don't have to add IV amikacin or streptomycin. There's no added benefit, only adverse effects. And in patients who have just nodular bronchiectatic disease, you can use your intermittent therapy versus patients who have cavitary disease. Usually you want to use your daily therapy. In patients who have rifampin-resistant disease, you want to add your fluoroquinolone instead of rifampin, and you want to treat these patients for at least 12 months. Coming to Mycobacterium xenopi, the main thing I want to highlight for you guys is why are we so concerned with when we have a Mycobacterium xenopi infection? So patient comes to you, they have positive microbiological results for active Mycobacterium xenopi infection. So what is the big deal? Why do we think this is different from pulmonary MAC infection? And does this subspecies require a more aggressive regimen for treatment, and why? And I'll kind of answer this by two graphs here. These are kind of pooled mortality. These are mortality studies in population-based studies from Denmark and Canada, respectively. And you can see that there's a 5-year mortality of 51% and 43%, respectively, for Denmark and Canada when infected with Mycobacterium xenopi. And in compared to the other species, you can see how it is definitely has a high, contains, it holds more gravity when you're infected with this subspecies versus Mycobacterium avium complex or Mycobacterium abscesses, for example. So if you have a patient who has Mycobacterium xenopi, do you use a fluoroquinolone regimen or one without a fluoroquinolone? Just very simply, there was one randomized clinical trial which randomized these patients to either getting ciprofloxacin or clarithromycin. And in these patients, when they were treated with either agent, there's no significant difference between in these two regimens in terms of death, cure, recurrence, or adverse effects. One of the main outcomes from the study was, again, harping on the previous point, is which the 5-year mortality of these patients was 57% despite treatment versus 31% in Mycobacterium avium complex disease. And I just want to emphasize this point is to show you guys that it does make a difference what the subspecies is, especially in terms of talking to your patient about their outcomes going forward. So because there is no difference between a fluoroquinolone and a macrolide, you can use either one in a multi-drug treatment regimen for this disease. Then we're keep on saying that this, Mycobacterium xenopi is such a severe disease, very high mortality rate. So is there any benefit for adding 2 drugs, going 3 drugs, or going for a 4-drug regimen? So there are actually 2 randomized controlled studies in patients with Mycobacterium xenopi that were conducted by the British Thoracic Society. One of them I put up on the slide here, which compares the efficacy of a regimen containing rifampicin, ethambutol, with or without isoniazid. So basically, it's comparing 2 drugs versus 3 drugs. And, it's a small study, 20 versus 22 patients, and there's no significant differences in death, cure, or recurrence. But again, obviously, it's a small study, so it's not very powered to detect differences in survival and things of that nature. But again, given the high mortality associated with Mycobacterium xenopi, it's felt that you want to go for a 3-drug regimen versus a 2-drug regimen, just based on how poor the outcomes are with this disease, and you do not want to risk treatment failure or relapse in these patients. The third question we want to answer is, should I add IV amikacin? So remember, we talked about in patients who had severe bronchiectatic or cavitary disease or macrolide-resistant MAC disease, we usually reach for our IV amikacin or streptomycin. So can we apply the same thing to our Mycobacterium xenopi patients? And actually, a lot of this data actually comes from just murine models. This is a murine model study that used an inhalational infection model, and they treated them with, a macrolide regimen or fluoroquinolone regimen with or without amikacin. And what they saw was the addition of of amikacin actually had a positive microbiological benefit, and clearance was improved of Mycobacterium xenopi in these murine models. So barring compelling evidence to the contrary, the patients with xenopi should be treated aggressively. You have to have all hands on deck, and you want to add your IV amikacin or streptomycin to these disease to the treatment regimen. And then, what is the optimal duration of treatment for this? There's no studies that evaluated the association of duration of treatment with outcomes, but kind of pooling 3 studies together. What I made this like little graph for you guys to understand is that they did have studies with different duration of treatment regimen. So you have the study in France that had a 27% clinical and microbiological conversion rate if they were treated for 5 months. This is a study of 122 patients. If you increase that treatment duration to 6 months, a study in Croatia showed that this increased the bacterial conversion, the sputum conversion rate to 50%. And if you went all the way up to 9 months, you actually increase that up to 58%. So there is a clear linear association between the duration of treatment and treatment outcomes. And for that reason, it is suggested that you treat these patients for at least 12 months beyond culture conversion. To kind of summarize our findings for Mycobacterium xenopi, in patients with xenopi pulmonary disease, you want to use a regimen that contains at least 3 drugs, rifampin, ethambutol, and then either a macrolide or fluoroquinolone. They're equivalent in effect. And then because it's such a severe disease with poor outcomes, high mortality rate, you want to add IV amikacin to treatment. And you want to treat them for more than greater than or equal to 12 months more beyond their sputum culture conversion. Finally, we come to Mycobacterium abscesses pulmonary disease. So, you have a patient that comes in, there's a 3rd patient in your clinic, and they have Mycobacterium abscesses. You call your senior fellow, and you're struggling with what regimen to use, and even your senior fellow is stumped, and they struggle to answer the question. And I will go through the reasons why this is such a tough question, and what factors decide the regimen of choice for this subspecies. So, in patients with Mycobacterium abscesses, do you want to use a macrolide-based therapy, or do you want to use a therapy without macrolides? So generally speaking, there are 4 studies that compare treatment outcomes in patients with infections due to Mycobacterium abscessus and then its subspecies. So just to clarify, Mycobacterium abscessus has a subspecies that's also called abscessus and has a subspecies that's called Miscellaneous. In those 4 studies, over 200 patients, they saw that culture conversion rates ranged anywhere between 25 to 42% and 50 to 96% when you compare the 2 subspecies against each other. So if you have subspecies abscessus, you have a lower culture conversion rate versus Miscellaneous, which has a higher culture conversion rate. And one of the reasons that's actually very interesting is the presence of the ERM41 gene. So this is the gene that actually allows for resistance against macrolides. It is non-functional in the subspecies Miscellaneous, and that's why you see culture conversion rates much higher in those patients with macrolide regimens versus patients who are infected with subspecies abscessus. They have a functional gene. It doesn't mean that all of them are resistant to macrolides, but they have inducible resistance, and that's why you often have these culture conversion rates that are much poorer. This also highlights the importance of macrolides in the treatment of this disease. So, having resistance to macrolides almost halves your sputum culture conversion rate. So it delineates how important a macrolide is to the treatment of this disease. And for that reason, patients with Mycobacterium abscessus, long story short, is they definitely should be treated with a macrolide-containing regimen. There are some interesting caveats to that, is that you want to look at the subspecies. So it's not enough to just say Mycobacterium abscessus. You want to look at their subspecies. Is it Miscellaneous? Is it abscessus? Is it Boleti? Because abscessus and Boleti have inducible resistance via this gene versus Miscellaneous does not have inducible resistance. So in patients who have inducible resistance, who may develop macrolide resistance, you can add the macrolide, but it is added under the pretense that you understand that it is only added for immunomodulatory purposes rather than for treatment of the disease. And it should be added in addition to a separate 3-drug regimen. So on that topic, how many antibiotics do you want to include in your regimen for Mycobacterium abscesses, pulmonary disease? This is just basically a systematic review that looked at many different case series and their treatments for Mycobacterium abscesses. And the thing I wanted to highlight here is, number one, there's a very poor pooled sputum culture conversion rate of about 0.34. The rate is 0.34, so 34%. So very poor response to antibiotics. And then the second thing I wanted to highlight is all these case series, all these retrospective case series always used regimens of 3 drugs or more, never less. Given that fact and given the usual disease severity of Mycobacterium abscesses and the potential for drug resistance, it's suggested and highly suggested that you use at least 3 active drugs in macrolide susceptible disease and at least 4 drugs in macrolide resistant disease. So to kind of summarize that point, again, just coming back to the subspecies, there is a subspecies that has macrolide resistance and a subspecies that does not. And in the subspecies, which is subspecies mesaliense, when you have no risk of macrolide resistance, the way you treat those patients is you use a macrolide regimen, and you have an initial phase where you choose basically any of the drugs listed in this column. So you can use amikacin, imipenem, tigecycline. You choose 2 oral medications, macrolide along with linezolid or clofazimine, and then you have a continuous phase in which you choose 2 or 3. You use at least 3 drugs, azithromycin with clofazimine, linezolid, or inhaled amikacin. And basically, what I wanted to highlight here is that even the panel of experts that decides these guideline reviews can't make up their minds in terms of what is the optimal therapy for Mycobacterium abscesses. This is just not known. But the point of this slide is just to kind of harp on the same point, is that if you have macrolide susceptibility, there's no risk of resistance, definitely go forward with your macrolide regimen, and you compare that, you have a overall regimen of at least 3 medications. If you have a subspecies that has macrolide resistance or can induce macrolide resistance, you want to add that macrolide for sure, but under the understanding that is only immunomodulatory, for example, preventing Pseudomonas infections, preventing other, having anti-inflammatory properties, but you have to combine it with a separate regimen that contains at least 3 or 4 medications. The last question I wanted to answer was the question of whether surgery is beneficial for patients with non-tuberculous mycobacterial disease. And there are actually 3 studies that reported the results for patients treated with combined antibiotic and surgical therapy versus those with antibiotic therapy alone. This is one of those studies where a retrospective observational study between 2001 and 2008, their aim was to look at microbiological outcomes for these patients with surgery and antibiotics versus antibiotics alone. And if you look at there were significantly more surgical patients than medical patients who had culture conversion and remained negative for at least 1 year, significantly 57% versus 28%. But I do also want to bring your attention to the fact that there are associated surgical complications that were seen in as many as even up to 35% of these patients. And they included things like bronchopleural fistula developments, prolonged air leaks, pneumonia, things of that nature. But if you look at overall, the quality of data is low. However, looking at the overall results from these 3 studies, the cure rate, death, and recurrences are not significantly different between medical and surgically treated patients. And this is coming from a data pool of about 300 patients. Given the fact that it's not associated with improved treatment outcomes, usually surgical resection is usually you want to have expert consultation before you enter into that realm. And it can be used as an adjuvant to medical therapy for patients, especially with severe fibrocavitary disease. But usually it has not, at least in retrospective studies, shown to have any additional benefit. With that, I have mostly covered the 2020 guidelines that for treatment of the non-tuberculous mycobacteria. I hope my mic was functional throughout that entire presentation. But if you have any questions, I would like to answer them now. You can put them in the comments or speak. And I would also like to thank Dr. Jennings, who gave me wonderful advice and saying that add more pictures, put less words on the slide. And I did strive my best to do that. Thank you. Thank you, Dr. Weiss. I think it's just you and me left. All right.
No, I'm here.
Oh, you're okay.
Very
Perfect.
thorough, Dr. Hashmi.
Okay. Thank you, Dr. Hussein.
Very thorough. Thank you.
Yeah, very good, very good.
Okay. Oh, perfect. Everyone.
Pictures.
We're all here, Danielle.
Okay. Awesome. Awesome. Alrighty. Thank you,
Thank
everybody.
you.
Bye-bye.